I'm glad that everybody's still here. This is the final live cases from the Asan Medical Center. This is 13 complex PCI. D.W. Park and myself, Alan Yeung, and we have on the panelists Dr. Baek, Dr. Basavarajaiah, Dr. Cho, this one is hard, Chunhamaneewat, Dr. Lam, Dr. Lee, Dr. Lim, Dr. Park, and Dr. Wong. So we're going to go to Asan Medical Center with the first operator being Jinhyun. Hi, Jung-Min. This is Alan. Welcome to the final session.
Hi, Alan and Duk-Woo. This is actually final session of the live demonstration. So we prepared a very classified left main and diagonal bifurcation disease, very complex cases. So I'd like to introduce my team, Dr. Baek. So we'll introduce the patient with brief history. Good morning, my name is Park from Asan Medical Center. I will introduce this case. This case is a 67-year-old male referred for the reportedly chest pain. The angiography shows severe stenosis from left main to the LAD bifurcation. So we plan the LAD left main to LAD PCI next. His cardiovascular risk factor is 2. And clinical presentation of stable angina, TCTAP function class 2, next. ECG shows normal sinus rhythm and no significant density change, next. Chest X-ray shows no significant finding, next. Echocardiography shows normal average systolic function and no region of almost abnormality, next. In right coronary system shows no significant stenosis, and in caudal view, we can see the long left main and diffuse calcified disease at the left main to mid-LAD next. And we can see the severe stenosis at the mid-LAD and heavy calcified region and bifurcation region next. The target region is left main to mid-LAD and diagonal bifurcation. We plan the IVUS and rotabulator atherectomy. So, could you show us the coronary angiogram today? This is a cranial view, show that the very diffuse calcified lesion from the shaft of left main to the mid-LAD, and diagonal branch also very calcified lesion. Diagonal branch bifurcation and left main is a bifurcation. But I think it's a very complex case. So, do you have any comment, any suggestion?
Okay, we have some discussion from the panel. Yes.
I always hate these calcified vessels because also you have two branches that are calcified, right? The diagonal and the LAD, and so you kind of need to think about modifying both. Yeah. And the LED is sort of subtotal. You barely see a lumen there. So the question is that, if you wire with a regular wire and change it, remove the microcatheter and change the rotablator wire, the microcatheter may not cross. So something to think about sort of going ahead is, getting ready for everything.
And I would like to add more comment is the calcium is very eccentric. So after stenting, sometimes you shift the carina. So you need very good calcium modification on the LAD, and possibly, it depends on the IVUS finding, you also need to rotate the osteodiagonal.
Yeah.
Yes, I do agree. I think this one definitely, I will do IVAS first and then probably rotation arthrectomy. This diagonal is very important because, it is big, bifurcating, and there is no visible diagonal branch after this. So, but the good thing is I think we can do rotablator of the osteodiagonal first and then, treat LAD later on. I think that would be my plan.
So in Hong Kong, Taiwan, diverse, calcium modifying tool is available like orbital atherectomy and lithotripsy and the IVL, shockwave, and the rotablation. And which one do you use for such patient?
I think for this one, definitely I will try rotabation first because it's very eccentric and likely the causing will be very challenging. So rota should be the first choice.
Rotablation, first choice.
Yeah, in Thailand only rotablator is available, but I would like to see wire bias from the IVAS because if the bias is not good, we can use extra support with a wire.
Honestly, for me, I don't think the diagonal looks really tight at the moment. I suggest maybe you can wire the diagonal and assess with the IVAS as well.
So Jung-Min, I think most people would say rotablator here. So
Yes, so from the beginning, we planned the rotablator first because the wiring is also very difficult based on the angiogram, very tight stenosis. So we saw the IVAS from the diagonal to left main, so the very calcified lesion. But from the beginning, I'd like to do rotablation. So we ready for rotablation.
You already passed the wire to the LAD. Yeah.
did you use primary wire, or you have to use a regular wire in exchange for rotablator wire?
Yeah, exchange to the after the regular wire successfully across the lesion and change to the microcatheters,
Okay.
and then this is extra stiff the rota wire.
Yeah. Can you briefly comment on which guiding catheter and
This is a Jung-Min left guiding catheter, the A French transfemoral approach. So we favor always for the complex PCI procedure, we favor the transfemoral and large bore guiding catheter.
yeah, you just use Jung-Min catheter
Yeah.
rather than the XP or.
Can I ask what kind of the wire, what type of wire are you using? This is extra support or is this just regular wire?
Yeah, this is extra support wire.
Let him fix that lesion first.
Rota both sides is 1.25 or 1.
This is 1.5. 아트로핀 좀 주세요.
I see some bradycardia. Will you consider give some atropine before rotabation?
Yes. 아트로핀 좀 주세요.
It's hemodynamically very rapid change. Bradycardia.
I mean, the good news that you can actually pass a microcatheter across, because sometimes microcatheter won't cross, and it's like a painful thing. You try to use a rotablator wire, it's not the best wire. So
We give some atropine
Yeah.
to increase the heart rate, and it takes time. And let's
And
see.
what RPM are you doing this at?
RPM is more than 180.
180? Doesn't sound like 180.
Maybe we can ask the panel what is the usual speed while you start the rotabation?
Can you use
This is 18.
180, more than 180.
I think for the distal type pipe, we need a high-speed burr, while for the proximal one, the calcium is more eccentric, maybe slow burn speed is more helpful. And actually, the calcium lines on the, lower border on the left side of the mid-LAD, maybe an extra support wire is more useful in this case.
Can I ask the panel also, how many of you, because as Lam Ho has spoken, it's eccentric calcium, who would actually wire and assess the wire bias of this rota before deciding whether it's going to be floppy or extra support?
For this case, because it's very tight lesion, you put you may not be able to put iverson. Even you put iverson, is a very small lumen, so you see nothing. For my practice, I will always use 4P wire in this eccentric case, unless it can't ablate anything, then I step up to extra support, because the risk of perforation is quite high if you use extra support.
For me, I'll try to put OptiCross IVAS catheter in first, because I think the profile and pushability is quite good. I think it is worth trying.
I was pleased.
So in your practice after rotablation, you're gonna do additional shock wave or additional atherectomy? Is it right?
For this case, I always water short. In fact, for this eccentric calcium, you can only do 3 things: amphetamine, IVL, and then pay.
Jung-Min, I like your way of doing rotablation. That is to do it very slowly. But personally, I would run the burr for a couple more times so that I can take down the thick calcium. But in your practice, in your case, I saw you only run few runs. Could you tell the difference?
So did you? I don't think that the purpose of the rotablation is just passing through the plug modification. So I don't think there is a big difference between the two strategies.
Sometimes we do step by step going up the rotor size 1.25, 1.5, and our conventional is after passage 1.25, and then we do IBUS evaluation. IBUS caster was passed well. That is guarantees a non-compliant ball. Any size of a non-compliant ball can work. Yeah.
So what is a successful rotablation? In my decision is that if IVUS catheter can pass through the calcified lesion, I think the rotablation is good. Rotablation result should be good. So look at the IVUS findings, very calcified lesions. So from the mid-LAD to here is just below the diagonal branch. This is 360 degree, almost 360 degrees, a very calcified lesion. Yeah, this is the diagonal branch. Diagonal branch ostium looks fine, but we have to see it from the diagonal branch.
Yeah. So Jung-Min, you actually don't have IVL. So here the question for the
Yeah.
panelists is that you don't have IVL, what would you do next?
So the next should be the high pressure balloon dilatation using NC balloon. So we know the vessel size, so that we can apply the very high pressure using a little bit smaller than vessel size.
Well, my thinking is that given that this calcium is 180 degrees, if you use the high pressure balloon, it does not make difference. However, using the shockwave catheter, it does make a difference.
Shockwave test. Yeah.
Yes. So I hope in the near future we can use the shockwave.
Problem is
Unfortunately,
very expensive.
What is the size of the burr? Will you consider further step up the burr if you do not have IVL?
Jung-Min, do you plan to
so
do
the
additional
1.5. No, I don't like to do further rotablation because So once the IVUS catheter passing through frankly speaking, I like to do the high pressure balloon instead of.
You now apply to the non-compliant balloon.
Yeah.
Yeah.
Do you want to run an IVUS from diagonal? At this
We
time?
already saw the IVUS from the diagonal. Please show us that IVUS from the diagonal branch, please.
This is microcaster.
This is distal part of diagonal branch. Diagonal is not so small, around the 3O vessel. So here is a proximal calcified diagonal branch, 2.5, 2.0 something.
This is ostium of diagonal branch?
No, not yet.
Not yet. Wow. diagonal branch. Wow, very tight.
So, could you show us that the ostium of diagonal branch? Okay.
Oh, yeah, okay, good.
Here is, run please.
It's ugly.
Yeah,
Wow.
very ugly.
Ugly.
Very ugly.
And the LED is pretty
On the
ugly
wire,
on
please.
on the other side too. Very ugly overall.
Ugly and ugly.
But ugly is good, meaning that now you have to treat both, and you don't have to think about it
Yeah,
too much.
right.
Because versus
So,
that, it's
from
half
the-
ugly, then
From the beginning,
Yeah.
we planned that the two-cent technique for the left LED diagonal bifurcation because based on the the ostium of diagonal branch is very calcified, very small and very with calcification. So
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 after
my
seeing
concern
this
is-
IFIS, will you consider rotablator also to the diagonal?
yes, it is good. That is a good suggestion. So I try to the high pressure balloon first.
Okay.
If the balloon cannot passing through the diagonal branch, definitely I have to do the rotablation for diagonal branch.
I mean, it's a little complicated, right? Because you have to kind of get the LED wire out and all that. But I think it's just ugly. But I don't think it's
yeah.
napkin ring calcification. So I think you
2.5
can deal
high
with
pressure
balloon on the
balloon, please.
diagonal.
So my feeling is about Jung-Min, as a last closing case, you selected much complex case.
No, I didn't select.
you regret.
All right. So high pressure balloon to all LED and diagonal, right?
Yes, diagonal first
Diagonal
because
first,
I
of
want
course.
to see that. Yeah.
Basically, it's to
To check
release
the
all
cross
the
line.
lesions so that you can put stents in with the least amount of resistance.
Yeah.
Nowadays, the DCP used for the side branch is very popular. In this case, will you consider DCP the diagonal?
I'd like
But,
to
I
protect
can-
the side branch, and balloon gelled technique is probably better.
So default
Balloon gel and then provisional.
Yeah,
Deflation.
provision.
Yes, for me, I rather do DCB in the side branch because, it is heavily calcified, but it is focal. So I hope if we can do good lesion preparation, we can do DCB of the side branch and we can do only provisional stenting of the LED. It will be less complicated.
Okay. Jung-Min is what size is
Okay,
NC
but-
balloon for diagonal?
2.5 NC balloon. 18.
2.5.
Yeah. So the NC balloon is fully dilated, 2.5. So the deflation. So I think we don't need the
Yeah.
rotabulation to the
Yeah.
diagonal branch.
The IVIS told you that basically it wasn't
Yeah.
completely concentric, so just a lot of plaque, a lot of segmental calcification. So, I mean, in those situations,
So
I
this
just
is-
hate that it would have dissections and hard to treat with just a DCB. And that concept is still kind of a nice concept, but it's not proven to be really to be durable necessarily.
So in case of very calcified disease, sometimes a big dissection acutely across the side branches. So the balloon jade technique and other other techniques are sometimes not safe to protect the diagonal side branches. So we prefer, in such cases, we prefer the upfront two-stent techniques instead of
This is the same balloon, 2.5, right?
2.5,
Okay.
18.
And I think in this case, if the
20,
side branch ostium is
24.
calcified, you always find a
Deflation.
lot of recoil even after you modify.
25,
And it's such a big
24.
diagonal, so yeah.
Deflation. So the balloon is well dilated. 20, 24. Deflation. 24. Deflation. 24.
What size balloon in the
So
LED, Jimin?
This is a 2.5.
Still too far.
Deflation.
Yes, NC balloon.
Yeah,
Okay.
2.5. Ready? Okay, big dissection.
Heavy dissection.
So please give me the 2533 for diagonal branch.
The diagonal
And
lesion is
then-
very long as well. That's why I would say
Yeah.
the DEB is not a great
You would like to
choice.
fully cover the stand, two stand technique,
Yeah,
right?
right. So the 3O high pressure balloon, please. 3O high pressure. Yeah.
You will do balloon crush technique.
Balloon crush first, yeah. So the balloon crush technique is very, I think many operators resist to do the crush technique because they thought it is very complex procedure. But once you learn the crush technique, then you may have some confidence to treat any kind of complex bifurcation lesion, because the benefit of crush technique is maintain the side branch flow. So patient is very comfortable during the procedure. Test.
And Jung-Min, you are comfortable too when you have to do that. So.
Yeah, it's kind of our daily practice. So sometimes more aggressive coronary anatomy we have to treat. Nowadays, the patient age is getting older and older. So 10 years ago, the 15% of cath-lab patient is older than 75. But nowadays, I think the one third of cath-lab patient age is older than the 65.
The main branch
Test,
NC balloon is a 3.5 NC?
30.
30. Is
Yeah.
what
Test.
size of stand length and diameter?
Stem length is stem length is 33 and 2.5.
2.5. And which stand
Test
you want to
please.
use?
This is giant
Giant
stem.
stand? Okay.
Yeah, implantation. Deflation.
This is a commercial question. Any preference for the drug-eluting stand for severe calcified region?
12.
Jung-Min?
Deflation. I don't have any preference, but yeah. So any kind of second generation, older than newer than second generation drug-eluting stand, I think there is no difference regarding the outcomes. So, but the different DES have a little bit different characteristics. So if you select one DES 2.5 high pressure balloon, please. 2.5 high pressure balloon, please. So if you're familiar with the one stand characteristics, and then it would be good. So you can use and thereafter you can use the contemporary generation DES. So TW also published some contemporary generation DES comparison in the left main stenting. There was no statistical difference between the contemporary DES platform. So after side branch stent implantation, somebody called it the side branch optimization, similar to the POT. This is side branch optimization technique. This is 2.5 high pressure balloon, increase more to oppose the side branch ostium, fully expanded 18, 20, deflation.
I think this is a
So this
very
proc-
important technique. Yeah.
Yes, this is facilitated rewire and balloon delivery. So if the particularly this case, the very calcified side branch ostium, if the stent is underexpanded, 10.
If you crush the 2.5 side branch, is it sometimes rewiring side branch so difficult?
18.
Yeah. Much big size side branch is okay, but this is 2.5 sometimes very difficult.
Deflation.
Nowadays, we almost routinely in all calcified bifurcation, we will use this technique.
12, 14, 16.
So this is a 3.0 NC in the LED?
3.0 NC,
3.0
yes,
NC.
deflation.
Okay.
Yeah.
You would like to fully cover the mid LED to the left main, right?
Yes, right. Ready?
I think Dr. Ahn, you really make a complex lesion to a simple procedure.
Yeah, diagonal branch getting bigger.
Good, much better.
Yeah.
So the
So-
coverage of the LED is sort of, oops, sorry, and then sort of the middle part, and then all the way to the left main, one stand, or that's too long, obviously?
Too long for one stand,
Yeah.
so I think that we need the two stand.
Yeah.
I see you don't
48,
remove the
please.
side branch wire
Two
while
five,
you do the
two five.
push.
Yeah.
Is it a
Two
routine
five,
practice?
48.
I see Dr. Ahn do not remove the wire during crush. Is it a routine practice?
No, this is my mistake.
Just not technique, mistake.
Usually, we have to remove the side branch wire before balloon crushing. But you know, the live demonstration, sometimes I made a mistake.
Jung-Min already exhausted.
But it's very educational. It highlights something.
Yeah.
Yeah.
This is
So
what
the-
size and length?
This is 2.5.
2.5.
The length is 48.
48.
The long stand delivery is not easy.
Why
Okay.
2.5 and not like 3.0?
Yeah, you like the fully cover. Yeah.
You think-
Test.
Even it's, yeah.
Okay. Looks good.
The key here is that you don't want to overlap at the diagonal,
Yeah,
right?
absolutely.
Then you have
Yeah,
these
right,
multiple
right.
layers and
Ready?
headache.
Okay.
You want to leave some room that your
Go.
overlapping stand would not touch the
Yeah.
diagonal at all.
10, 12. Okay. Fortunately, stand is very nicely expanded deflation. 10, 14.
Jung-Min, and for the true bifurcation region, you do 100% imaging guided PCI, and
Yes,
you already
100%.
use IBUS, and sometimes you're gonna use the OCT for the true bifurcation region.
Frankly speaking, I'm sorry to Abbott, but my preference is IVUS.
IVUS.
OCT, we can, yeah. Based on the Duk-Woo Park, the randomized trial, the Octavius trial, there is no difference between the OCT and IVUS for the routine treatment. But stand. So, but the user-friendly, I think the IVUS is more user-friendly than the OCT. 33. 네. 38 하면 됩니까?
Because this patient have a very thick eccentric calcification at the mid LED. So that's the reason in our CASAP, I always do a rotation for more than a few runs,
Right.
so that we can take out the thick calcium. So when you look at the stand, when the stand was expanding, you can see there was some still indentation at the inner curvature.
Yeah, right. So that's why the post-deal high pressure balloon dilatation is very important. After stent implantation, and I like to do LED stent optimization first using high pressure balloon, and then we'll try to rewire to the circumflex, rewire to the diagonal branch. Test, please. Too long,
You
please.
absolutely avoid the overlapping at the diagonal ostium. Yeah.
Yeah, right.
Will you consider doing the kiss now before you put the proximal stent?
Proximal stent, after the I'd like to do after the whole stent implantation and do the side branch intervention, because to simplify the procedure, the first side branch and second main branch only, and finally do the kissing.
And the people main branch stenting, if you do kissing balloon, there is absolutely TK crush. Yeah.
This is too long as well. Test. Too long. 28, please. Sorry. 28, please.
What was that one? That was 33?
Yeah, 33. So 28, please. Because if there is no bifurcation, so it doesn't matter to overlap, but to avoid the overlap at the bifurcation region, so the shorter stent is better than the longer stent.
Jung-Min, I like the way they choose the stent size. It really fits the vessel.
Yeah, but after the stent implantation, we have to see the IVUS. So I will react to the IVUS findings. Test, please. Okay,
That's
good.
better.
So, overlapped?
Not yet.
Not yet, not too much.
Not yet?
Okay, it's better to use the stent booster.
Overlapped.
Yeah, I think the angle you use for the left main stenting is very good. Although in classical teaching it's always say 20-20, but most of the time I also find this angle. You look at this his angle. Actually, this angle is quite useful, and most of the case can do left main stenting with this angle.
14, 16.
지금 메인 스텐하고
Deflation.
엔진 찍고 한번 봐가죠.
I think you can see the crushed diagonal stents a little bit at the little radio opacity there. That's you sort of
Yeah, right.
you set the little
That
line
is
there.
diagonal. Crush the diagonal.
Yeah.
Ready?
Sometimes you can see them, sometimes you cannot. Depends on the angle. But this one, I think, can see the crushed.
Okay, good.
Okay, everything is fine.
Yeah.
So I only left
You're gonna
only
do
left
final
the-
kissing balloon and the additional high pressure.
Yeah.
So
Yeah.
and Jung-Min, we're gonna move
Yeah.
to the another last room is done by SJ Park, and then we
Okay.
come back again.
So
Okay.
just before you go back, so there's a choice of using another wire, but I think pulling back the main vessel wire give you the best chance of not, have to go underneath the
After passage
stent,
of the
right?
side
So
branch
then
wire,
you go.
and then move to the another room. Okay, you passed away.
And then knuckle the LED wire
Okay,
down.
okay, take your
Yeah.
time, Jung-Min, and we will.
Okay.
Okay, come back again. Okay.
Okay.
Hi, SJ.
Hi, hello.
Hi. So we are
Can you hear
here
me all right?
with you for the last case of the 30th
right.
anniversary of TCTAP 2025. So I'm really happy that we are all here sort of seeing you sort of complete the circle, right? It's the last case of the meeting.
All right. Thank you, Alan. Really, this is a live cases. Last complex PCI session is, however, I would like to show is not too much complex. But you can take some less, right? And I'd like to introduce Kim Jinhyun, is our junior staff, and senior fellow Seung-Jung. All right, and anyway, we're gonna start case 4. So you present data.
Thank you, Professor Park. I'm Lee. Let me introduce the case. 62 years old female was referred for chest pain. Next. Her medical history was hypertension and hyperlipidemia, and her clinical presentation was a stable angina. Next. The EKG showed normal sinus rhythm. Next. And chest X-ray showed normal. Next. And the left coronary angiography showed severe stenosis at proximal to medial LED with severe stenosis at diagonal bifurcation. Next. This is her baseline coronary angiography. RCA showed normal, and caudal view showed diminutive left circumflex arteries. Next.
Dominant right system, right?
And coronary view showed the severe stenosis at the proximal to medial LED, and the spider view showed severe stenosis at the diagonal bifurcation. Next. And so our target lesion is proximal to medial LED and then the diagonal branch, and we're going to plan to IVUS guidance PCI.
Okay, would you show us this right coronary? Can you see that?
Yes.
Hello?
Yeah.
All right. Absolutely. Dominant system is normal. Okay, next. Next, please. All right, this is circumflex. Area view, another view, please. This is spider. It's clearly show that any significant stenosis, but D1 and some normal looking area, it's a proximal LAD. And the next, please, area or something. All right, great. So I think it's clear, not too much complex. However, separate two, vessels. Diagonal branches, jeopardy wire, fractional mass is concern is almost, same with the LAD, something like that. And so, all right, based on the angiographic findings, we're going to do, IRIS dose, we prefer that. However, would you discuss about in a big diagonal branch, significant stenosis and LAD, right? Anyway, still, a provisional stand and two stand or front
what
to
technique
two
would
stand
people
is
use?
a discussion point there.
Yeah.
Right.
I'm just going to ask the
Would you
panel,
discuss
SJ,
that?
what technique would they use? Are you going to do, everybody's going to do 2 stents here? Right? Because the diagonal is kind of a parallel LED. It's almost kind of do most of the work for the LED. Right?
This patient have the other clinical systemic disease. Actually, this patient is relatively young female patient, so the disease pattern looks very ugly. So I have some experience of some kind of arthritis or the autoimmune disease. So did you check up her other disease condition?
No, actually 62 is not, all right, young, relatively young. However, I believe this is atherosclerotic changes and so on. All right. Anyway, in terms of, how to do concerns around this.
Yeah,
still,
so I think
we have
IVUS
some
would be very
people
helpful
concerned.
because I want to see the size of the LED before the diagonal. So IVUS both? Take a look at.
We did.
Any,
would you show
additional
us
comment
how-
for the stenting strategy? Most people is agree two stents technique. Okay.
Agree 2 stand.
Interesting.
Yes. Okay.
This is already obvious.
To stand diagonal, first diagonal to the.
This is
Yeah,
LED IBUS.
Culot,
Yeah, so what type of
This
tube
is,
stent technique, I think
LED
the question.
pullback from, this is LED pullback IVUS.
3 and 3.5 vessel size, normal looking area, just the distal part of the region side, right?
Yes.
And discrete narrowing.
Very tight.
This is pretty much plaque and not too much calcium, but relatively soft plaques. All right. And
This is the diagonal coming in with a wire.
yes, 12 o'clock. And absolutely normal looking areas immediately after the diagonal is occurring. And big size, 3.5, more than full, almost full, right? Okay, all right, want to show the diagonal branches? I will stop. Okay, after summation of two imaging, and we're going to decide. This diagonal?
Yeah.
Great. 3.0. Big vessels.
Big vessels.
Even, more than 3, more than 3.
Yes. Wow.
Plaque starts,
Wow,
very
very
tight.
tight.
Yep.
Oh, yeah, pretty much plaque. Very tight stenosis. And,
joint.
LED, take them 6 o'clock.
Yeah.
Absolutely normal. And, all right.
So the LED is diseased at just before the bifurcation, meaning that the diagonal is very
Yeah,
tight.
yes,
When
it
just
is.
entering
Yes,
LED,
it
there's
is.
disease there. So
right.
you have to deal with that as well, with the whatever two stent technique you want to use. So what would people choose to do? What kind of two stent technique would do? Mini crush? Can you do a V stent here? Is a left? They say LED, proximal LED, big enough to take 2 stents simultaneously. Just any
So,
comments?
And any
But,
comment from the panel?
okay, from the panel
Go ahead.
first.
Anthony?
So, so in this case, I would prefer to do culot standing. I think the size of these domain vessels and the side branch, and they are quite similar. And I think the angulation is favorable for culot standing. I'll put the first stent in diagonal first, and then second stent from proximal to mid LAD.
I would like to do crush.
The culot. Yeah.
Crush, I think
Culot.
Poland wants to do crush, right?
I think the mini crushing is not bad, but the skewer technique is favorable.
Any different thought?
I prefer increased technique.
Okay.
Cooler, crush
Yeah,
it.
yeah. Crush versus Gulo. Okay. What is your purpose of the park and strategy?
All right, so Ju-Young Kim, Dr. Kim, what do you think? What are you going to do?
Well,
It's our new rising star, and so.
we always do a mini crush.
I will also
That's the answer to the big question.
I think Gillow is also a great option, but AMC style is always mini crush.
All right, and treat concern is definitely we have to treat them. Even in the diagonal branches though, and actually for the main disease concern, I just review the ABC data in the side branches, relatively short lesion length, relatively small vessel, maybe optional, strategy would be better. However, I believe or not believe, anyway, in a case of a big vessel, large size, more than 3, more than 2.5, actually stent would be good. Even in the region length more than 10 millimeters, a little long region, actually a little bit longer one. However, so we prefer truly bifurcation disease, 111011, any cases, we're going to do the upfront to 2 stent. So we have some show the data. So, okay, Dr. Kim suggests that we're going to do the crochet, mini crochet. So, what you've done? So, okay.
Yeah, so we already did a side branch stenting.
The stent size and length?
Yeah, the side branch was 3.5 and 15 millimeter. And the main branch also 3.5 high pressure balloon.
5, okay. Basic size-wise 3.2, 3.8, and so you're going to choose the 3.5, right?
Yeah.
Matches? Explain that.
So yeah, we were trying to slightly protrude the side branch stent into the main vessel, and we deployed the stent. And after that, we applied a high pressure at the side branch ostium, to just like the Professor Ahn told before. And then this is the side branch stenting. And then we did a balloon crush from the LAD with a high pressure.
What size balloon?
It was also 3.5.
3.5. And balloon crush first, right? And then, all right, so we're gonna shorten our procedure, and so Dr. Ahn will give us. Okay, we're gonna prepare a main branch LED stand after the balloon crushes, and so just.
Yeah, this is a main branch stand, 3.5 and 33 millimeter.
All right, we gotta choose 33. Actually, spider, please. I don't want to cover circumflex, a relatively small one, but I don't touch circumflex. A little bit more lateral, please. Okay, good, perfect. Test. More lateral, please. Okay, test. I think it's okay for the mini crush. We have to cover the proximal, just a minute, stent area, wire and test please. More stabilized status. And I want to just confirm the proximal part would be covered. Test please. All right, 0.5 millimeters, push in, test. The thing. It's okay? All right, inflate. What's wrong with this?
Okay.
All right, 35, 33. Okay, big, large stent, just a crossover. Okay, and also come back, previous view, okay. That's really,
I noticed Dr. Park also do a side branch awesome optimization, but this time it's not by NC balloon, it's by pull back the stem balloon and then with further inflation. This is a very convenient way.
Yes.
If in IFAS it's
Right,
not very calcified, this is a most convenient way.
and I take a picture first, and all right, the position-wise, in the spider view, there's shallow area cranial view is clearly, well deployed stent. And so, as the next step, we're gonna do maybe bigger balloon for all sides, a kind of a part technique, something. It's a high pressure inflation of the proximal part and rewiring downward branch. Finally, finalize kissing balloon inflation. All right, why not? We're gonna limit time, and so Dr. Ahn will give you some, final enjoy, and
right.
then come back. Please,
Okay.
right.
We'll come back, SJ. Let's go back to
no problem.
Jinmin's lab.
Okay, we're gonna move to the Jung-Min's case again.
Okay, show us the previous.
So last time we left you is that you will wire the diagonal using the LED wire, and then you're going to put your second
I
wire down
already
the LED,
did
right?
Next, yeah, please. 위에 거. Okay, please. So after you wire, so this is LED anchoring, and then try to passing through the side branch balloon. So 1.5 balloon first. Next, please. Next, please. And then, so this is next to this is LED optimization. Next, please. Okay. This is after LED optimization. LED optimization is very important because side branch is a side branch. If a patient something happen, I believe that main branch event is way more important than side branch event. So before side branch procedure, the main branch optimization is a very important step. And main branch optimization make a side branch hole getting bigger, so facilitate make it easy to recross the wire and recross the balloon. And so this is the next, please. This is 1.5 balloon, and this is the after anchor balloon technique. I used the 2.5 high pressure balloon. Next, please. So next, this is the high pressure balloon to the LED circumflex side branch ostium. So to obtain the sufficient minimal stent area to get by the sequential high pressure ballooning. This is 2.5 up to 24. So final balloon size around 2.7. Sequential next, please. And then this is a final kissing balloon. Next, please. So this is ready. Okay.
Can you show the final IBUS?
Okay, so I'm inserting the IBUS catheter. So this is diagonal. Diagonal is small.
Asan, this patient
yeah.
has very eccentric left main calcification. So,
Yeah.
what is your target vessel size of left main?
Left main is to obtain
Just the ordinary reference data, or you have some specific size measuring strategy.
But to obtain the actually left main is eccentric, but the left main vessel size is more than 5, around more than 5. So if left main is big, I don't care the eccentricity of calcification. So I care the eccentricity calcification when vessel size is small. So show us that the ostium of side branch. So
This is
run,
diagonal
please.
branch ostium. Okay.
Yeah, diagonal branch ostium looks very okay. Ostium is here is a very ostium.
Good.
So diagonal branch ostium is very nice, very well expanded. I'd like to show you that the LAD stent. Actually, LAD is more important than diagonal branch.
Jung-Min, I really like, before you do the kissing and recrossing the diagonal is really to optimize the LED stents, because as you know,
Yeah.
if you cannot cross, it's not the end of the world, because you have the main vessel treated already, and obviously restenosis rate is higher in that situation, but at least you have the vessel patency maintained. But most of the time you can cross, but getting the LED all done, I think is very helpful, and so that you don't come back and it's not expanded, and you have under the wire, all that, under the stent struts, all that complication.
Yeah, right. So I think this is very important because to simplify the procedure, and I like to say that the main branch optimization getting bigger the side hole of stent and facilitate the rewire to the side branch. So ironically, main branch optimization is make the side branch intervention easier.
So this is the LED, the IBUS, right?
Yeah.
So,
right.
Okay, and looking at the mid LED part, I saw there is some eccentric, seems like not fully expanded. The lamp and any other panel have. If you're gonna do further calcium modification using shockwave, can you guarantee much more concentric, much full, optimized, expanded vessel? How do you think so?
It is by luck, but I'm sure post-stent putting shockwave is no problem. But whether it's the efficacy is by luck. That's why I say it's obey, IVL, and then pay.
I think shockwave won't make it symmetrical. I think you will still achieve eccentric expansion, but you might get a better luminal gain.
I mean, it all depends on how thick the calcium is, meaning that, I've done cases that are post-radiation. The calcification is so thick that no matter what you do, it's not going anywhere. So I think, obviously, IVUS, you can't really tell as much, but most likely you won't get completely,
Yeah, Lam, and do you have experience after the final balloon dilation using NC balloon? Is it like, seems like there is a cell on the expansion? Do you have experience after stenting to additional shock wave?
I had a lot. We have done more than 500 or 600 IVL. We had some case on post-stent and then IVL. All case no SR, no ISR, touch wood, no ISR so far. We have
you can achieve for the larger lumen. It's a post-stenting shock wave, right?
Yeah. And one case, one short wave do not expand. We put another 2 short wave. Finish 16 cycle and then it expand. But we found the efficacy and response is by luck.
I think that this is a very good case for the post-stent shockwave treatment.
Okay.
So we have a lot of idea once we can use the shockwave. I hope that the next TCT AP 2026, I'd like to show you that the shockwave treatment on live.
Yeah.
So this is our final angiogram. So it looks very nice. The side branch is happy, main branch is happy. So everybody is happy. Patients don't complain any chest pain during the procedure. So we obtained the full dilatation of a stent. But even though because of eccentric and heavy calcification, stent lumen is smaller than the non-calcified coronary artery disease treatment. But I think this is acceptable, the result. Thank you very much.
Excellent job, Jung-Min. Make a very complicated case, really ugly looking, and now looks beautiful. Thank you.
Okay, we move to Thank you, great. You did a good job. Okay.
뭐지 이게?
3.25.
Okay. Can you see it?
Yes.
Yeah.
All right. So we are still, long way to go. It's pretty simple, focusing regions. However, okay, we're gonna do. Wiring again, diagonal branches, and you have already. This 3.25, right?
Yeah.
You're gonna do the high pressure.
Yep.
Diagonal branches, and okay, you do.
Yeah.
2.5. 잘 됐어.
이거죠.
6.25.
inflect.
Okay, inflate.
0.25 inflate.
What size is
24.
the side branch balloon? 3.25?
2.5.
2.5.
And see,
Deflection.
up to almost 16, 18?
24.
Okay, 24.
Yeah, we are performing a sequential high pressure.
So we're gonna do,
The
no,
Jinhyun
pull back the
NC
major.
balloon size is 2.5. In the stand, you put the 3.5.
Yeah,
Yeah.
yeah.
We actually a little bit, choose the bigger stand, and we're gonna show the arms in the later.
Yeah. Now it's NC
Okay.
balloon is 2.5.
Okay, side branch.
All right.
Side branch, yeah, inflate. 28.
It's okay. Ready, next.
Ready.
High
Yeah,
pressure.
inflate. 20. 24. 26.
Okay.
Deflation.
Proximal LED size-wise, it's almost 4.0, and so we don't too much worry about 3.5. Okay, final. 8.8.
88.
Perfect.
1, 2, 3.
Okay. Deplete. Full down to balloon. Simultaneously. 1.
You did the final
Then you
kissing
do-
balloon dilation. Is it Jinhyun? Can you comment LED size balloon and the diagonal size balloon?
Yeah,
Well,
the
well-
LED is 3.5 and the diagonal is 3.25. So we just apply
3.25.
the
Yeah.
yeah,
3.25.
sequence.
Yeah.
Yeah.
Full down.
Inf-
Diagonal 3.25.
6. 88.
Perfect. Deplete.
1, 2, 3.
Full down. Full down. Hold the system. And we're going to show angiographic finding first, and then I have to confirm, iris optimization concept. However, all right, take a picture.
Okay, ready?
Ready? I like it, right. Would you show the spider view?
Spider view, yeah,
Spider.
please.
I noticed Dota is doing kissing for twice. Am I right? Is there any reason to do that?
Kissing balloon dilation is twice, right? This is sometimes we do twice or three times, and depending on the position. Yeah.
That is also one tips and tricks. In fact, I also do that. If you got fever or bifurcation, you do double kissing twice.
Picture.
Why do you do double kissing?
Alright.
So you just try to expand it better, or what?
I try in model. If you do double kissing, the Kawaii optimization will be better.
Well, look like LED circumflex bifurcation. Circumflex is relatively
circumflex very small.
Okay, I just confused with it. The meaning is okay. Would you show us the previous view?
Minus.
All right. The
Excellent.
message from this case is actually it's very not too much complex one. However, this is clear. We've learned big vessel after it's more than 2.5. 2.5 we can discuss a little bit more. However, 3.0, just like a true disease bifurcation, we don't hesitate, upfront to stand. The reason why big stand area, even after optimization is really good, clinical outcome. All right, this is the last case, and it's about time. It's to close, and we have a long 4-day journey up to this point, and I really thank you all for the active participation. I really want to looking forward to seeing you next year so, and next year's to you all, even better program. So I really thank you for our colleagues, Dr. Ahn. So, okay, you finalize closing the.
Thank you very much, Alan, our long friends, loyal friends. Thank you. At the end of meetings,
Your teachers.
No, I'm the disciple.
Okay, so I think this year TCTAP 30th anniversary is really successful, and I can say thank you enough for every great panels and great faculties and audience and attendees. Without your devotion and contribution, we cannot make this kind of big event. So we will take a rest one day today, but we will prepare another 30 years from tomorrow. Thank you, everybody, and please enjoy. Please safe back to the home, and please come up again the next year.
All right.
Thank
Great.
you. Thank you.
Thank you.
Thank you.
Thank you so much. Yeah.
Okay. Finally, I would like to ask a closing remark. Yeah.
Yeah, no, I was going to tell SJ and Dr. Ahn is that on behalf of the faculty and all the audience that we appreciate all the hard work that you guys have put together in the last 30 years. That really is through you guys we learn how to do left main, how to do things that make complicated things simple. Meaning you can always make an intervention more complicated, very easy, but to make it simple is really understanding the underlying disease, the process. So I think that's really what I think TCTAP and Angioplasty Summit before that has taught many of us in Asia Pacific, as well as I think the world. So I think that's your contribution, and it's really long lasting beyond these 30 years. So thank you so much, DW, and
Thank you.
Thank you.
Thank you. See you. Everyone next to see you. Thank you.
Excellent.
Yeah.
Excellent.
Yeah. Thank you.